Thank you, Jasper. Thank you, all the delegates, and thanks for your time. Yeah, it's hopefully I can give you tonight just a bit of background, have a look through the eyes of the medical fraternity and doctors. This can be quite a large topic, and but I would like to break it down in small little chunks and how the man in the street can handle this, because it's quite a common problem. So let's start off first just by looking at a few definitions again. What is pain? And I've used this slide before. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And then pain is always subjective. Now, I want you just to focus on, it doesn't have to mean that there is actual damage. It's just how we perceive pain. And there's a brilliant video that I got this week of how we can fool our brain regarding pain sensation or sensations. But just the basic bottom line is it's an unpleasant sensory and emotional experience. And that's why we always experience it as a negative. Now, as far as the chronic definition for chronic pain, that is pain that lasts beyond the normal healing time of an actual illness or injury, or more than 3 to 6 months. For instance, if you break your leg, it's probably going to take you about 3 months to heal. If you have pain beyond that 3 months period, then we classify it as a chronic pain. Or if you had an operation and your scar should be healed within 3 to 6 weeks, any pain beyond that period is then classified as chronic pain. And I just want to touch on this again, on the 4 types of pain that we normally define. Nociceptive pain is typically the result of soft tissue injuries. Your inflammatory pain is an abnormal inflammation caused by an inappropriate response from your body's immune system. Neuropathic pain can be pain, nerve irritation, or an injury to a nerve. And then obviously functional pain is pain without an origin or a cause that we can find. Typically, we can give an example like fibromyalgia. Right. And then just looking at the causes of how doctors normally should think about the cause of these chronic spinal pains, we look at degenerative disorders, trauma, obviously, tumors or cancers that spread to bone, your infections, typically like tuberculosis that can spread to bone, spinal deformities like the scoliosis that we see, congenital disorders, in other words, people that are born with congenital disorders or spinal deformities, inflammatory disorders, and then your metabolic disorders, which is your autoimmune diseases and so forth that can all, diabetes, for instance, can all mimic spinal symptoms. And then in the next few slides, we will also look at these extraspinal conditions that mimic spinal pathology. So I've put in this slide purely just to say that your thoracic spine has very specific things that we can look out for, especially in older people, the degenerative disorders, fractures, neoplasms or cancers, and infections. Now, those are the things that you don't want to miss because they are potentially life-threatening. So doctors should always exclude cancers, infections, and fractures. The rest is probably not that life-threatening. And then obviously neurogenic or spinal cord problems or neoplasms. And then blood vessel malformations, which can sometimes, this is the gray canaries with pink tackies that doctors sometimes miss. Right, and then if we look at non-spinal causes, intrathoracic, we can think about the heart and the vascular system in the chest cavity that can all give referred pain to the spine. Your lung problems, lung cancers, pneumonias, or even a lung that collapsed can give you spinal symptoms. In the mediastinum, tumors or cancers can manifest there and give referred pain to the back. And then also intra-abdominally, your liver, your spleen, your pancreas can all give referred pain, or peptic ulcers can give referred pain to the back. And then your kidneys and aneurysms can also give referred pain. And then the last non-spinal causes that I want to look at is the musculoskeletal, or your muscles and your skeleton, the different syndromes that we get there, or pain. And then a very important cause that we hardly ever look at or overlook a lot of the times is biosocial causes. Now, I just want to stand still with this one quickly. Any form of mental or psychosocial burdens that we have will always put us in a fight and flight mode. And I've spoken at length about this in previous talks. But think for yourself, your spine is the thing that keeps the body erect. But your spine is not like a skeleton that we see in pictures. It's an active substance or organ itself, and it's kept erect by ligaments and muscles. And the moment the body goes into a fight and flight, your big muscles or your back muscles go into a spasms, or they contract. And I want you to have the physical picture of a vice grip. The moment your back muscles go into a spasm, it's like pushing your vertebrae into a vice grip. Sooner or later, something's got to go. The harder you press and contract, the problem will be. And then also vascular problems, your aorta, and if you get blood clots in the aorta, or the big vessels, or aneurysm, those things can all give referred pain to the back. Now, I think before we start, it's good to just look at the anatomy. And this excites me if I think how intricate we were made. The vertebrae consist of a vertebral body, and then there's the pedicles, which connects the front part or the vertebral body to the back part, which I like to call the Y bone or the spinous process. And then you've also got the transverse processes, which all the muscles and ligaments adhere to. And at the back, you've got the facet joints or articulate surface. And in the middle, these bony structures form a little hole here, which your spinal cord runs through. So on top of that is the vertebral discs. And the disc also contains two parts, basically the central part, or the nucleus pulposus, which is a jelly-like substance, and the annulus fibrosus is the outer layer of the disc, which is more a hard rubber-like substance. And this is the shock absorber of your spine. Think about if you put a load on it, this disc is there to absorb basically all the load on the spinal cord or the spine itself. Now, I want you to, for a moment, stand still and think about yourself. If you stand erect against the wall, put your ankles up against the wall, your shoulders back up at the wall, and you look up, you will feel that your lower back has a curvature. You can normally put your hand quite easily behind your back, between the wall and your back. That curvature is called a lordosis. And it's also repeated in your neck if you look up. So if you stand and walk away from the wall, you should have what I call the Titanic posture. Head up, shoulders back, and with an erect spine. Now, when we have that position, our center of gravity goes straight down the middle of the vertebral bodies. The moment we drop our shoulders or bend forward, the center of gravity moves backwards through the facet joint. And this is where most of our problems start. Most people don't walk like little soldiers. straight up with shoulders back, head up. We normally all have curvature to the, or flexion to the front, bend forward, and that puts strain on our facet joints. And over a period of time, this will obviously cause wear and tear and give us symptoms. The next thing is, if you take the height of this disc away, it means that that height is more friction on the same height is more friction on the facet joints, which will also cause symptoms. So with age, most of us lose our height of our vertebral discs. So to a certain extent, this can be a normal pathology in every person on Mother Earth. So why does some people get the symptoms and others not? And we'll have a look at that. So also, if you stack all the vertebrae on top of each other, you will see it forms a little hole here where the spinal nerves exit, or the neural foramen. And anything, if the disc or any bony protrusion or protrudes to this foramen, it will obviously can irritate the nerves coming out here. So if we look in short, basically, of the structures that can cause pain, it's obviously the vertebral body, which can have fractures, or any bony part that can have fractures. We can have disc pathology, and we can have a look at some of that, or anything that happens in here that can irritate or put pressure on a nerve. And that, in short, is basically how we look at causes of back pain. Right, just to go back to give you an idea of how our nervous system works. Remember, I said previously that basically our nervous system is just an electric current that connects the peripheral areas of our body via the spinal cord into the brain. So if you get a pinched nerve or a joint that hurts, it will send via different nerve fibers a signal into the spinal cord, up into the brain. The brain needs to digest these information and decide, is this danger to me or is it safety to me? And if it doesn't know what to do, it will send a message back so that you can react. Send a message back that you can react, pull away your hand from a hot plate, or to heal that sore place or joint, it will cause inflammation. Now, the important part here is that 90% of, or 80% of lower back pain is not dangerous. That's good news. And it will 9 out of 10 times, or 8 out of 10 times then, recuperate on itself. But it do take time. So before we start, or if you go to a doctor, the best, or the basics is a good history and a good physical examination will reveal 90% of the causes of back pain. And that's good news, because it's something that we can diagnose up front and treat accordingly. Sometimes we need special investigations, or most of the time we need special investigations just to confirm our diagnosis and to rule out other causes like cancers or infections. So in the least case, we normally do a X-ray just to try and exclude fractures or deformities. And we can get a lot of information from a normal X-ray. But remember, an X-ray only tells you bony pathology. It doesn't tell you anything about soft tissue injuries or pathology. Right. Now, what makes doctors so clever, or look so clever? We know that every nerve supplies a certain part of our body. So if we learn, or we call these areas dermatomes or myotomes, if you know which nerve supplies which muscle. But in general, we normally look at the dermatomes. If a pain is referred, in which direction does it go, or where does it manifest? So the L1 nerve, maybe I should go back quickly just to say that we number the vertebrae from we've got 5 lumbar vertebrae or lower back vertebrae, and we number them from 1, 2, 3, 4, 5 till the bottom. So if we talk about the nerves, the L1 nerve exits below the between L1 and L2, and L2 nerve exits below L2 and between L2 and L3, and so forth. So if we look at the L1 nerve, it normally is the anterior thigh. It supplies the anterior thigh, the L2, the anterior thigh and groin area, and L3, the anterior and lateral thigh. The L4 is the medial side of the leg and the foot. And your L5 is the lateral side of the leg and the foot. And I'll try and, the medial side is the inner part of your leg, and the lateral part is the outer part of your leg. And then your S1 is the lateral and the bottom part of your foot. So just a schematic illustration of this, like I said, your L1 normally supplies the anterior part of your thigh, and L2 the groin area. L3 is mostly on the side of your thigh. L4 the inner side of your lower leg and calf. L5 the outer side, and then S1 the small toe and part of the outer part of your ankle area. And then the sacral nerves all supply the part around your buttocks and your private parts. So if you know the dermatomes, it's quite easy. If a patient walks in and he says he feels the pain shooting down his leg into the lower part in the inner side of his leg, then you know it's probably an L4 nerve root that's irritated or pinched. Right. So just another term or definitions, the difference between radicular pain and radiculopathy. Radicular pain is normally if there's an irritation or a compression on a nerve root in the lower back or the neck. It's normally just on one side, and it will give you a referred pain. It spreads from the lower back into the buttocks or into the leg or groin or thigh, whatever. Normally in the thoracic region, it will give you pain to both sides. So if you get pain on both sides, then just think about that the pain cause might be a bit higher up. And normally the patient will experience pain overlying the spine and in the muscles overlying that area where the pain is. And if you compress on the root, the patient will normally jump through the roof. So a fairly clinical diagnosis, you can establish at which level the pathology is. Whereas a radiculopathy is a neurological condition. That's where there's damage to the nerve or compression on the nerve, where you get normally the patient responds with or presents with a numbness or a tingling sensation. But the important thing is there's weakness in the muscles and there's sensory or motor loss, outfall. So these patients are normally, they are an emergency. They need immediate attention. Right. So a simple thing is, believe it or not, the history and physical examination remains the mainstay to evaluate lower back pain. So 9 out of 10 times you should be able, or your doctor should be able, to make a clinical diagnosis, and you don't need very expensive investigations initially to make the diagnosis. The danger part to doing too much special investigations, I normally say, like we have wrinkles on the outside or tissue damage on the outside, we also have wrinkles on the inside. So if we look at statistics that of special investigations, especially on MRI scans, disc degeneration, at the age of 50, 80% of us have disc degeneration, but we are asymptomatic. And if you live long enough, just about 100% will have disc degeneration. All right, disc loss, for instance, just about 60% of patients will have a disc height loss at the age of 50. And it's staggering, at the age of 80, 80% or more will have that diagnosis. And then the normal thing that we all see on X-ray, on MRI scans is disc bulging. So at the age of 50, 60% of patients can have that sign on an MRI and have no symptoms. So if a doctor looks at a MRI and see a disc bulge, that doesn't mean to say it's the cause of the pain. So your clinical picture needs to correlate with what you find on a special investigation. Otherwise, you will make a wrong diagnosis, have a wrong procedure or surgery for the wrong indications, and the patients will still have pain afterwards. So very important that you first make a diagnosis and then confirm it with your special investigations. So just in general, if we look at these causes again, disc pathology or disc degeneration, that's just plain old age. Disc signal loss, and I'll show you a bit of that, how we look at the MRI scans. Disc height loss, which normally contributes to a facet joint pain. Disc bulging, it just means that that disc it's losing its elasticity, and if you put a bit of pressure on it, it's like a balloon that's under pressure. If you press it, it will bulge to the side. Disc protrusion is normally if that it's like a tennis ball bouncing back into the spinal cord or on the nerve. And then annular fissures is if there's a tear in the disc. Now, most of our disc pathology is basically associated with an annular tear. The outer part of the disc that tears or get little cracks in, and which then can cause symptoms of pain. The facet degeneration, it's a most common cause. Like I say, most of us should have this symptom if you think about just losing the height of it. And then spondylolisthesis is if there's instability or movement of one vertebrae on another. And you can think about yourself that it can pinch a nerve or even put pressure on the spinal cord itself. So let's see, what do we look for if we have a history of back pain? Normally it's a radiating sharp pain or a dull pain, a piercing pain, throbbing or burning. If you get these type of symptoms, it's normally a nociceptive pain. In other words, some form of soft tissue involved or irritation of soft tissue. Pain caused by a herniated disc classically increases by bending forward. So classically, the patient will give you a history. He was lifting something up and it was an excruciating pain and he couldn't get erect again. Or when we sit or cough or sneeze, in other words, when there's excessive pressure on the spinal cord, especially on the lumbar discs, it will cause pain. And it's normally avoided by lying down or when we extend or come erect, or sometimes just by walking, it gets better. So a disc pathology doesn't like it if we sit for long periods of time or if we stand for long periods of time. And classically, these people are normally the people with a bad posture, sitting in front of a computer screen the whole day or sitting in front of a TV with a weak posture. And then inversely, the pain from a lumbospinal canal stenosis, where there's a narrowing or pressing on the spinal cord itself. These are typically the older generation patients, and you will see them often walk in the mall, hanging over a trolley, bending forward. And they normally can walk fairly far if they bend forward, but then if the pain comes and they go and sit, the pain subsides. So these are just things that we look for in the history, because if you listen to the history, you can actually make the diagnosis just by listening to it. In addition to pain, the patient also reports paresthesia or an affected dermatome, in other words, pins and needles sensation. Then we start thinking, especially if the pain goes beyond the knee area into the feet, then you know there's probably a nerve that's pinched or an irritation of a nerve root. So the facet joints, and this is what causes most people's back pain. The prevalence range from 5 to 15% of the population, and 80% of people in their lifetime will experience some form of pain, back pain. Like I said, fortunately for us, most of them subside by itself. Arthritis is a prominent cause in facet pain, and it's normally a disease of more older people. It's the wear and tear of our bodies that catches up to us, and like I said, it increases with age. The predisposition factors for that facet joints, or we've got a nice big name, zygapophyseal joints. See, I even struggle with it. Includes basically if there's movement on the vertebrae or the joint itself, or if trauma or fractures or degenerative diseases that rheumatoid arthritis and stuff like that can play up to us, and obviously the bad posture. As we age, we tend to have more flexion or bending more forward, and that can place more stress on the facet joints. Like I said, mostly if the pain of the upper facet joints normally extend to in the back or to the flanks, the side of just to the off center, and to the hips, and if it's in the lower part of the facet joint, normally goes into the hips, the lower buttocks, and the thigh region. So basically, if you can distinguish between where the cause lies just by looking at how the pain spreads or where it localizes. And like I said, if the pain goes beyond the knee, normally then it's not just a facet joint, then there's probably also an irritation of some sort of the nerve roots as well. So in summary, if you look at facet joint pain, classically it's a pain that spreads from side to side. It's not constant there. It's sometimes better and sometimes worse. Some people have it more during the night and early in the mornings and get better during the day. Others get it more if they towards the end of the day, and it's definitely something that increases with rotation. So classically, the patient will tell you if he stands up out of bed or get out of a car, it's excruciating pain. Now, I've just given a quick, don't want to go too much into this talk of an MRI scan, but basically what we do is if we do the scans, we look for certain things. Now, you get different types of lumbar spine scans. This is a sagittal T2 scan. In other words, it's a cut through vertically through the spine from top to bottom. And if we, again, number the vertebrae, a vertebrae should be square. And in between the discs, you should be able to see the height of the disc. Now, on this particular T2 screen, everything that's water will show up as white. So this white is the cerebrospinal fluid around the nerve, and this is your spinal cord. And you can see basically the spinal cord ends between L1, L2, and thereafter it just branches little nerve roots, which we call the cauda equina, or the horse tail. And if you look at this here, you can clearly see a disc bulging also here, but then something excruciating must be going on here. And you can see that there's quite a bit of pressure onto the spinal cord itself. Now, just looking at this, we can say this is probably an older patient. You look at the end plates or the edges of the vertebrae, that's normally should be a square line, not like this mottled type of lines. And then a normal disc should be full of water, and it should be relatively white. Now that looks fairly white, but if you look at the rest, you can see there's definitely not good, these are not good discs. And obviously this patient had a lot of disc pathology. But the thing that we worry about here is what's the clinical sign. So if we do a cut through that area over there where the purple line is, you get what we call an axial line. And again, this is just looking at a cross section. You will see the iliopsoas muscles on the side. And here's the vertebral body, all right? And because we're on that level, it means that we're just on the edge of the bone. We're not in the disc itself. But what's interesting here, this is where the spinal cord runs. If you look at this is my V bone at the back, or the spinous process, and this is where the nerve roots should exit. And somehow you can see that whatever is going on here, there's some of the disc that's protruding in and around to the back of this spinal cord. And if you compare the nerve on that side to that side, you should see that there's some form of a density or something here that's probably causing pressure on this nerve root. So this is the L3-4 nerve or L3 nerve exiting here, and it should give us symptoms clinically, if I got to take a guess, in the L3, L4 nerve distribution down in the leg. Right, so this is basically what our doctors interpret these things. It can be very tricky. It's not always straightforward, but what we have here is then a disc extrusion or a disc that ruptured, and part of the substance are causing pressure on the spinal cord. So what's the treatment for these lower back options? Mostly conservative, and the biggest message I can give is prevention. If we look at our backs will look at us. So a good posture, neck up, chin up, shoulders back, and look at how you sit and walk. This will be a good prevention from getting lower back pain. Obviously, exercise, strong muscles, strong ligaments, movement will definitely prevent you from having long-term sequelae of lower back pain. All right, so like I said, proper back care, posture, exercises including back, abdominal, and the back stabilizers. Stretching and strengthening is very important. The hamstrings, the gluteus muscles, your big buttock muscles, and the iliopsoas muscles is the big biltong muscles on the inside of your lower part of your abdominal cavity on the inside. These muscles keep us erect, right? And then the piriformis muscle is a very, very sly little fan-shaped muscle in your buttocks. And if this muscle starts irritating you, it can cause quite a bit of discomfort in the buttock area, but it can also pinch the big sciatic nerve. And so if we can strengthen our muscles and our core of our pelvis, we can normally prevent a lot of lower back problems. Okay, just as a rule of thumb, ice in the acute phase, heat in the chronic phase. So we normally see the rugby players get a bag of ice and we think the pain police is doing a great job. What literally happens is we reduce the inflammation. All right, so in the first few hours, if you can use ice on an injured area, it will help a hell of a lot to reduce inflammation and heat up or speed up the healing. But once you have a chronic disease, heat is normally the best treatment for the chronic phase. And why? Is because it enhances blood flow to the sick area. And blood is the thing that heals us. Blood brings food, blood brings oxygen, and it takes away or flushes away all the toxins in our body. So the more we can get blood to this area, the faster the healing or helping heal the body. Right, and then over-the-counter medication, we normally use the non-steroidal anti-inflammatories, your Voltarens or diclofenacs or whatever generic name you get these days. But just be warned, these things can have other side effects as well, irritating your stomach, bleeding tendencies, and so forth. So this is not stuff that we should be using long-term, just in the acute phase, maybe for the first few days. Right. Activity and maintenance is probably a long-term more lookout. The way we sit, looking at our ergonomic factors, get good chairs when we sit in front of a computer, make sure that you get proper breaks and not sit 24/7 in front of a computer, or if you do, make sure that you get enough periods where you can stretch your back muscles, your shoulders, your neck. Right. And then my takeaway message from this is the treatment of lower back pain is motion is lotion. Whenever we have pain, we don't want to move. But if we don't move, there's no circulation, means there's no blood coming to that affected area, and it's just going to take 10 times longer to heal the back. So even if you do have pain, try this motion is lotion, that it enhances the blood flow to that area. Right. Conservative treatment, like I said, we normally use the anti-inflammatories and cortisone. I like to use cortisone for 10 days, but it's also just for the right indications. Cortisone reduces inflammation. It works brilliantly to reduce inflammation and probably then your pain, but it doesn't always have the good effects long term. Chronic pain, we use all these tricyclic antidepressants, different, the newer age depressants, anticonvulsants, or gabapentin or pregabalin. And in the acute phase, I would suggest maybe opioids like Tramadol or oxycodone, but opioids are not indicated for long-term chronic back pain. In fact, it can make your chronic pain worse. You can get a condition that we call opioid hypersensitivity or hyperalgesia. So the more opiates you have, the more your body wants, and it's quite a nice way of becoming addicted. So I do not promote opioids for chronic long-term back pain. Important thing here is exercise therapy. This is where your physio, your chiropractor comes in, is to mobilize you. And because you have pain, hurt does not equal harm. It doesn't mean that you're going to get paralyzed or injure a nerve, or that you will even aggravate your cause. Probably not. So the more we start with stretch and strength, mobilizing the joints, the muscles, the better we get. And maybe here I can just divert again. Have you ever asked yourself, when you stand up in the morning, why do you do this stretching and pulling and stuff? Most of the time during the night, because the muscles don't move, we all get a bit of inflammation in the muscles. And the moment we start stretching and strengthening, we enhance the blood supply to that muscles. And in no time, the body feels hot, the muscles feels hot, and you start moving without any pain or stiffness. Now, the same happens when we have a muscular injury or inflammation in the muscles. When we start moving or exercising or stretch and strength, we increase the blood supply, and that's how the body cures itself. Obviously, for patients with a neurological loss of function due to a herniated disc, immediate surgical treatment is indicated. That's when that horse tail that I've spoken about is pinched. And that is very, very seldom that we see that. Most of the time, a patient will present with a neurological outfall or loss of control of his bladder and bowels, and obviously numbness in the legs or weakness in the legs. And that's an emergency, but that's very rarely that we see that. And probably the only indication for surgery in the acute phase. Right. So let's just focus on the treatment. We can do epidural cortisone injections. We can do diagnostic blocks, basically just to go and inject local anesthetic in that areas or the joints. Discograms is where we go and inject dye into the disc itself to see how it where it spreads. But mostly this discogram has been we can see a lot of detail on MRI as well. So this is not something that's routinely done. Sympathectomies in some cases for lower back pain. That's more associated with if there's referred pain from the abdominal cavity organs or the thoracic cavity organs. And then rhizotomies, where we get two types of rhizotomies. That's where we basically numb the nerve or cause a conductivity disturbance so that the impulse can't go up to the brain. A pulse radio frequency is where we use a radio frequency to just cause an electric current over 2 points, and we basically cause a conductivity disturbance. So between say the dorsal root ganglion and the spinal cord itself, so that a current can't or an impulse can't be conducted up to the brain. Or if you want to destroy the nerve, we can use a radio frequency where we can heat it up to 80 degrees and then have a more long-lasting effect of a conductivity disturbance. These procedures are not permanent. All right, they last for a few months, maybe 9 to 18 months, or in some cases up to 3 years, and then one has to redo these procedures. Now, just quickly to give an idea of what can be done, we know that the posterior or the nerve root has a branch coming off the medial branch that supplies the facet joint. Right, and there's normally a little branch that come on the same level that the nerve root exits to supply the top part or the lower part of the joint, and there's a little branch from the lower part supplying the top part of the next joint. So if you say, for instance, that you've got an L3-4 lesion or L4-5 lesion, you always have to go a level higher to block the nerves. Otherwise, you might still end up with experiencing facet joint pain. So these are just, if we put a needle right next to the nerve root, we can inject dye, identify the nerve root, and then do a pulse radio frequency. On this lateral view, you will see this is basically where the spinal cord runs, and we can put a needle into this epidural space or just next to the nerve root and then do a pulse radio frequency where we also just cause a conductivity disturbance, so to reduce the patient's pain. This is not always curative of the cause, but it can alleviate the symptoms a lot. And this is just from the side view. Whenever we put these needles in, obviously we don't want to go into the spinal cord, so we make sure that we do different views to make sure that we're not in the spinal cord on top of a nerve root. In conclusion, always start with a good history and a proper physical examination. You can ask yourself at home, if you feel a back pain, was there an incident? Did I lift something? Was it rotational? Is it when and how do I experience the pain, or what type of pain? Is it electric shock, or is it just a burning dull ache? And normally if we do these, a good physical history and physical examination and a history, one should get a good idea of what the pathology is. Like I said, we need to exclude red flags, cancers, infections, and fractures, because those are the things that's potentially life-threatening. If you can rule out that, 9 out of 10 times, even though your pain might be excruciating, this is not life-threatening. And it will cure itself most of the time over a period of time. If needed, we normally do special investigations like blood work, x-rays, and maybe an MRI scan. And normally an MRI scan is indicated if you suspect that a patient will need surgery. It will also just confirm your diagnosis. For instance, you can say there is, or make a clinical diagnosis of a disc protrusion or something irritating the nerve, but we don't always know exactly how bad it is, and then an MRI is indicated. Bone scans we normally do to look for inflammatory processes or diseases, or even cancers that spread to bone. So 9 out of 10 times your GP should be able to get away with normal non-steroidal anti-inflammatories, your Voltarens or I don't want to mention too much names here, or just plain cortisone, a good bout of physio, and we can sit on these things for 3 to 6 months. Just remember, motion is lotion. So in the acute phase, I will say maybe an opioid, but thereafter, please stay away from these things. They can make things clinically worse and not necessarily help the patient or the disease process. Once we go beyond these things, then obviously, if the pain doesn't settle or doesn't get under control, we need to refer the patient to a specialist who can do these interventions or perhaps look at surgery. So if conservative treatment fails, referral to a specialist is the treatment of choice. The advanced treatment modalities, like I said, the interventional procedures, like I showed you now, the rhizotomies, steroid epidural injections, nerve stimulators are mostly indicated for patients with chronic long-standing pain, those who had failed back surgery, or quadriplegics or paraplegics who's got chronic nerve pain. Or then this intrathecal pumps is where we put medication into the intrathecal space to try and control patients. But this is more the advanced type of pathology and not the routine stuff that we would do. Right. Surgery is your last option. And yeah, I would really... Unfortunately, I think we do too much back surgery for the wrong indications. It's definitely a place for it, but we've got to select our patients. And once you had back surgery, you most of the time just functional, you're never normal again. So first go do everything in the what's possible conservatively before you go for surgery. And that's about my talk, Jasper. Let's keep it short and sweet.